Good evening, everyone. Welcome to Voices of Healthcare. So, we are here now with a neuro twist, that is vestibular rehab topic with Dr. Disha. So, let me just introduce Dr. Disha first. She is a neurophysiotherapist with 7+ years of diverse clinical experience. She has practiced in government hospitals, and private clinics. She did her Bachelor's of Physiotherapy from SETGS Medical College and Came Hospital, Mumbai, and her master's was from University of Pittsburgh, USA. She have a keen interest in neurorehabilitation, prenatal and postpartum rehabilitation. She is also a co-founder of Rehab Praxis, that is a platform which provides continued education for practicing clinical physiotherapists. So today, if you have any queries related to vestibular rehabilitation, or you want to pursue MPT neuro, and if you want to ask anything, you can ask in the chat box or in the end in our Q&A session. Okay, so over to you, ma'am.
Thank you, Dr. Payal, for the lovely introduction, and good evening, everyone. I hope you have pen and paper ready, or pencil or paper, whatever, something to write down stuff about today's session. And also, if you have any questions, do feel free to ask them towards the end of the session. Okay, so what is today's topic? Today, we are going to talk about vestibular rehab, the very basic stuff, but these tools will hopefully help you do better during your clinical practice. And let's get started. Okay, so what is vestibular rehab? First of all, so it's an umbrella term to explain all the physical therapy strategies that one does to ensure vestibular habituation, substitution, and adaptation. So, how it works, how the vestibular system works. So, first, there are peripheral inputs, sensory inputs from the eyes, the ear, your proprioceptive system, and your mechanoreceptors from the various parts of your body, which sends sensory information, relays sensory information to the central nervous system, where sensory integration and processing happens. Then there is a neural command that is sent to the executing muscles of the various parts of your body, which causes muscular movement, which causes change in posture, which again sends a sensory input to the CNS. So that's very short on how the vestibular system functions. Can we go to the next one? All right. So the vestibular system, as I described, has two broad classifications or two parts to it, which is the central vestibular system and the peripheral vestibular system. Let's talk about the peripheral first, because that's where your input comes from, your sensory input comes from. So, two major organs which help to identify change in posture, change in balance, that is the semicircular canals and the otolith organs. So, I'm sure you've heard that there's a snail shaped organ inside the ear, which I've actually highlighted in the image below, right in the middle. So that's some part of it is the semicircular canal. So they are positioned at 90 degrees to each other. And the otolith organs are the utricle and saccule. And I'm not going to go into further details about function and stuff because it's all theory. And we want to talk more about clinically relevant stuff. So feel free to go ahead and read up about it from your ENT textbooks. Then the central vestibular system, parts of which include the oculomotor nuclei, the cervical proprioceptors, medial and lateral vestibulospinal tracts, the cerebellum, the parasympathetic nervous system, the thalamus, and the parietal and insular regions of the cerebral cortex. So, as you see, the vestibular system is not only restricted to the inner ear. We have a whole another system which we don't often talk about, that is the central nervous system, which is actually the mastermind behind the whole function of the vestibular system, and what we're going to actually use to perform vestibular rehabilitation. All right, next one. Okay, so how do you identify whether there's an issue with the peripheral vestibular system or the central vestibular system? So, nystagmus is involuntary eye movements, which we actually observe to see if there's an issue with the balance when somebody complains about balance issues or vertigo or dizziness. So in central, it's only vertical, often downbeating. So to understand further how to observe nystagmus and stuff, you need a whole entire class on just nystagmus, to be honest. So we'll add on it further some other time. And for peripheral pathology, there's a vertical and torsional. So it could be upward or downward, and torsional is a bit of rotational component. Then vertigo is often uncommon in central pathologies, more common in peripheral. Other symptoms in central will include diplopia, that is double vision, lateropulsion, for example, what happens in Pusher's syndrome. Then there could be altered consciousness and infrequent hearing loss. And in a peripheral pathology, there is often hearing loss, fullness, the feeling of fullness in the ears, and tinnitus, that is ringing in the ears. Also, other signs that you could find in a central pathology is abnormal smooth pursuit or saccades, persistent ocular tilt reaction, which is a type of skew deviation. I will explain more about what these different words mean. And smooth pursuit and saccades are usually normal in peripheral pathology, and there is no fixation of nystagmus. There's no suppression of nystagmus when there is fixation in a central lesion, but it does happen with a peripheral lesion. So, what are smooth pursuit movements of the eyes? So, one very important part of your vestibular assessment is checking the eye movements. So, I'm sure as part of neurological exam, we've heard of checking visual acuity of how well the eyes can see. So we've heard of the Snellen's chart, all of that. But in addition to how well the eyes can see, we need to also check how well the eyes move. Because eyes are organs that you can actually look at and observe, and they do indicate a lot about how vestibular function is occurring. So there are three major types of eye movements that you look for in a suspected case of vestibular dysfunction. So very smooth, slow movements will be smooth pursuit. So for example, if I go, I'm looking at the tip of the pen and I just slowly look right, left. So I take about 2 seconds to go from right to left, for example. So that will be a smooth pursuit. I'm not moving my head, I'm only moving my eyes. So this is a smooth pursuit. You do up and down and diagonals as well. So this is called smooth pursuit. Saccades is a faster movement, and an example of saccades being used in daily life is actually reading. When you're reading, you're trying to catch up with how the words are placed in the paper. That's a very good example of how saccades work. And the middle one is the VOR, or the vestibular ocular reflex, where there's a medium speed of movement. So something like when you turn your head, for example, somebody calls you, and for example, I'm just looking here, and somebody calls me from the right, and I quickly look there to see what is happening. So when my eyes move to the right in accommodation to my head movement, how quickly my eyes catch up with the head movement determines how clear my vision will be. So somebody with a VOR dysfunction may have trouble moving their eyes fast enough with their head and will probably have double vision or blurring of vision. So that's why VOR is also important, and another tool to examine how the vestibular system is functioning. So that's about the basic three eye movements that may be required to check in a vestibular dysfunction. All right, next one. So, this is not an exhaustive list of disorders that will benefit from vestibular rehab. So, to broadly classify peripheral vestibular disorders, there could be reduced vestibular function, fluctuating vestibular function, or distorted vestibular function. In reduced vestibular function, where overall the function of the vestibular system is suppressed, there could be vestibular neuritis, that is inflammation of the eighth cranial nerve. There could be labyrinthitis. So the entire inner ear, most of the inner ear is enclosed in something called a labyrinth. So that entire portion could be inflamed, for example, could be due to a post-viral complication. Then there could be chronic unilateral vestibular hypofunction. This could often be due to as a response to a prolonged inflammatory process that could happen. And there could be bilateral vestibular disease. And one example is Dandy's syndrome. Then there could be fluctuating vestibular function where some days it works well, some days it does not. So, one great example is Meniere's disease, where there are certain pus filled or certain sacules that are formed inside the inner ear. There's no known cause to this happening, and occasionally it does rupture, and that's when there's a reduction in vestibular function. So there could be dizziness, frequent headache, fullness in the ears, hearing loss, partial hearing loss during that episode, and it does take a few days or few weeks to settle, and it could be recurring in nature. And unfortunately, there's no known treatment as such for Meniere's disease. You only need to learn how to manage and identify the episode coming on, and make sure you don't have a fall during that kind of stuff. And I'm sure you've heard of something called BPPV, that is benign paroxysmal positional vertigo. It's one of the most common types of vertigo you will probably encounter, and people have often heard of. So, when people usually say vertigo, they're most of the time referring to BPPV. So, that's where you do the modified Dix-Hallpike. So, what we actually call these days as Dix-Hallpike test is a modified version, because the original one, the one who actually designed it, included consumption of lithium, and they restricted movement of the head and neck for about 2 days after the maneuver was done, which is not done in these cases. Like recent cases, we don't do it anymore. So it's a modified version of the original text. So that's the peripheral vestibular disorders. Then examples of central vestibular disorders are vestibular migraine, concussion or head injury, stroke, cerebellar disorders, vertebrobasal insufficiency, certain psychiatric conditions like anxiety, panic disorder, agoraphobia, acrophobia, and hyperventilation syndrome, and multiple sclerosis. Again, not a very exhaustive list. There are many more disorders, I'm sure, you'll probably encounter. And there are certain things you need to look out for when you decide how to assess a particular condition, as holds true with other conditions as well. So I think so. The basics for now I've covered, I think.
First of all, can you just write the spelling of the test you mentioned
The
in the
Dix-Hall
chat
pipe?
box?
Yes, I will do that.
Hmm. And this were the basic of vestibular rehabilitation, na? Means
Very,
types.
very basic. Very basic,
Okay.
because further details, a lot of practical stuff needs to be done. So,
Exactly.
yeah,
Hmm.
yeah. Dix-Hall pipe test. for
And
Okay, I've
everyone, you
sent it
can
on
take
the
this.
Dex, on
Okay.
the chat box.
Okay.
Modified Dix-Hall pipe test.
Okay. Everyone, you can take the screenshot also. Otherwise, we are
Yes,
going
yes,
to upload it on YouTube, so you can
yes.
see this PPT on there also. Okay.
All right. So I spoke a lot about how to identify vestibular. Central versus peripheral, but we often hear.
Anurag.
Anurag, can I answer that in some time?
Okay.
Yeah. So, like I mentioned, we do see central versus peripheral, for example. but we often hear people using the term vertigo and dizziness interchangeably, including healthcare professionals.
Exactly.
Yes. So they are often mistakenly interchangeably used, but they're very different things. So vertigo is quite specific, is a very specific term, which in which what happens is the person feels like either they are spinning or tilting, or the world around them, the environment is tilting or spinning. And there are very specific triggers again. So something like change in positions. For example, in BPPV, often what a patient complains is turning from side to side, or bending forward, or driving, or walking down a grocery store aisle, for example, can be certain triggers. And yeah, so that's vertigo. There's a spinning sensation. And also, there'll be associated involuntary eye movements like nystagmus. When you actually do the eye exam, you might find nystagmus. When you do the Dix-Hallpike test, you'll find a nystagmus. And the patient will very specifically tell you that they have these particular triggers, and every time they do that during the active episode, the same symptoms come up. There could be nausea, vomiting if it's quite severe and it's a recent onset of symptoms. Whereas dizziness is a more broad term, and there's no specific spinning sensation as such. You may feel lightheaded, you feel like you're about to faint, but there's no spinning sensation as such. And triggers will be more like low blood sugar. If there's low blood sugar due to dehydration, for example, if there's low BP, if they have low hemoglobin, so those will be more of the kind of triggers that will happen. Also, you will not usually find vertigo in central causes. You'll see them more in peripheral causes, like anemia, for example, or low blood sugar. Or, for example, if they're taking too many medications called polypharmacy, that often happens in older adults because they have a lot of things going on medically, like they have sedatives, they have BP medication, they have sleep medication, for example. So all of those interact and produce these side effects. So they'll probably have dizziness and not vertigo. And this is why you need to do a very detailed medical examination, and take a detailed history. A lot of things you will identify using the history to figure out what to do next.
Okay.
Yeah.
And ma'am, is there any proper assessment for vestibular cases?
Uh, so a lot of vestibular assessment is similar to what you do in neurological conditions,
Okay.
because vestibular rehab or vestibular system cannot be actually isolated from the other systems of the body, as we saw
Yes.
in the previous slide. So there's a whole vicious cycle that keeps going on. The entire body keeps talking to each other. It's
Hmm.
not just the inner ear or the brain that is functioning to maintain your balance. Your eyes are being used, your ears are being used, your joints are used, your muscles are used. So it's a whole body thing. So vestibular system is not only in the inner ear or the brain, it's the whole body that has the vestibular system.
Okay. And ma'am, can you tell us about epidemiology of vestibular cases? Like males में ज़्यादा, females में ज़्यादा, और area wise, something like that.
So that will vary depending on what is the cause of the dysfunction. So peripheral vestibular disorders, often there's no difference between area or male or female, not a lot of difference in those. But central causes, uh, for example, a stroke could be more in male patients in younger age groups, because estrogen has a protective effect till you're done with menopause. Then the risk is the same. For example, like a migraine, it will usually be more in females, because females tend to have more histamines, especially certain females tend to have more histamine dysfunction, due to which they'll probably have associated period issues, for example. Then something like a head injury, again, depends on how the head injury happened, whether there was an accident, or whether they had a sports injury, for example. So those, again, from case to case, it will vary.
Okay,
So
means there is
yeah,
no specific
no,
gender differentiation, right?
no. It all depends on what is the cause of the problem.
Okay. And ma'am, in India, how many cases you have treated till now?
I've lost count honestly because because every neurological case, almost every neurological case, you are technically working on the vestibular system when you
Okay.
train their balance, when
Hmm.
you train their gait.
Yeah. Okay.
Like I said, you can't isolate the vestibular system.
Hmm.
Whenever you're training a neuro case, you are technically doing vestibular rehab.
Okay. So every neurophysio should know this.
Yes, very important because balance and gait training are very important parts of vestibular rehab. Of course, if somebody has like a BPPV, for example, you need to do certain maneuvers, which again needs hands-on practice to do so that you don't end up injuring them. You also need to know how to modify certain things. If there's an overlying condition like a cervical injury, for example, you may not be able to do the exact maneuver as you are taught.
Hmm.
So, which is why hands-on learning is required.
So, is there any two, three maneuvers or more than that?
I'm sorry, can you repeat?
I'm asking, like, we also taught in the hospital that there is some maneuver for vestibular rehab assessment.
Yes, yes.
So, are there
So
many or just one, two?
there are a lot, many, but there can be a few that you can learn. So my personal favorite, especially for uh, home rehab or when you want to give it as a home exercise program, is the brander of exercise. Very standard, straightforward.
Hmm.
Especially for somebody who has a BPPV or somebody you want to habituate with respect to dizziness, for example, a central cause in a stroke. If somebody is not able to tolerate simple head movements, you
Hmm.
use that. So in brand off, you sit in the middle of the bed with pillows on both sides and you slowly lie down. You take your time. You take about 30 seconds to a minute till your dizziness settles. Then you again sit up. You take time till the dizziness settles, which is about a minute or so. Then you lie down on the other side and then you sit up. So that's one cycle. So depending on severity, you may increase the number of cycles, you may decrease it. And it's pretty safe to do, obviously under supervision, but
Hmm.
pretty safe.
Okay. Like many physiotherapy students are curious about vestibular rehab. So, what basic skills should they start learning? Like Anthony asked for that.
Hmm.
Apart from
Hmm.
that, what else?
So, before you are very excited about jumping to vestibular assessment and rehab, you need to do a very thorough neurological examination. Also, medical history, surgical history, family history, all of those things matter a lot because often, if there's a complaint of dizziness, it's not due to a vestibular dysfunction. It is very basic stuff like dehydration, anemia, polypharmacy, that is taking multiple medication for a prolonged period of time. Could be anemia, could be excessive stress. So you need to figure those things out first and then think about other causes that we spoke about today.
Okay. And ma'am, could you share a patient case where vestibular rehabilitation made a remarkable difference?
Okay, that reminds me of a case I saw about 3 years ago when I was working in a private hospital. So this was a 38-year-old who had sudden onset of dizziness, nausea, vomiting, and eventual unconsciousness. And turns out he had a PCA stroke. So he was admitted in the hospital, in the same hospital where I used to work, and I saw him after his discharge when he came as an OPD patient. So before the stroke happened, he was an active individual. So he used to go for tennis matches, he used to gym, all of that. But when I saw him for the first time on his first day as an OPD patient, he refused to move his head from side to side. Like even this was a big problem for him. He would just refuse. He would guard his neck a lot. He would refuse anybody touching him to move him around. So transferring him from the wheelchair to the plinth treatment bed was a huge task. And eventually, with vestibular rehab, so like I mentioned earlier, Brand Daroff, that was the only exercise with vestibular rehab per se that I worked on. Of course, we started off with mat exercises, all of those things. We worked on turning in bed, because very important skill to have, turning in bed. And with the gradual habituation, he did eventually progress to standing balance exercises and walking on unstable surfaces, walking with head turns, looking to the sides, looking up and down. And we also then trained him for agility training, and he was back to what he used to do before. So he was back playing tennis. He started regularly going to the gym, all of that. So that is one case that remains in my mind all the time when anybody mentions vestibular rehab.
Wow, great.
Mhm.
So, ma'am, like if a physiotherapist encounters a patient with vertigo, okay, for the
Mhm.
first time, so what
Yes.
should be the first three steps they should take?
So before I start with the steps, you figure out whether it's dizziness or it's vertigo. That's number one. Then the three steps will be you check their vitals, you check if they've eaten well that day, and then you proceed to checking their eye movements. So the eyes will tell you a lot, and then you proceed to do everything else that you want to do. So you need to do a thorough eye exam and then proceed further.
Okay. And ma'am, how to differentiate between dizziness and vertigo?
So, vertigo is a spinning sensation or tilting sensation. You will feel like the world around you is spinning around when you're, especially when you're triggering the vertigo. For example, if I have a BPPV on the right side, turning my head to the right will be a huge trigger, for example, or bending forward might be a huge trigger. Looking up, walking down a narrow path would probably be a trigger. So when all of these, I'm in those situations, I'll feel like the world is spinning around me, or I'm going to tilt to one side, for example. Whereas in dizziness, what we say as chakkar aa raha hai, or you feel lightheaded, you feel like there's a blackout in front of your eyes, those are dizziness. Those are signs of dizziness.
Okay.
So there's no spinning when you are dizzy.
Okay.
I think Anurag had a question. Do the vestibular rehab therapists see MS patients as well? Yes. Uh, so usually people are not specifically vestibular rehab therapists. They do see overall neurological conditions. Why MS patients they do see is because often, especially in women, MS is quite the frequency of female patients having MS is a lot more because unfortunately, it's an autoimmune condition. So females are more likely to have a lot of these autoimmune conditions. So often, the first symptom that appears in multiple sclerosis is dizziness. So, which is again why you need to figure out how the dizziness started, and you need to do a medical history and a surgical history, all of those things. So yes, so MS patients often you probably maybe the first one to actually see them and figure out why they're having dizziness. Anthony has a question. What foundation concepts? Uh, so for So, for a first year student, especially, focus on getting your neurological examination thoroughly ingrained in your brain. That will give you a lot of answers to further understand vestibular rehab, because basic of vestibular rehab is um, basically figuring out how to make sure the patient does not have a fall. That is the number one thing that you need to focus on to prevent a fall. You need to also work on making sure if they have any double vision, for example, how to help them stabilize their gaze, how to help them stabilize their vision, and how to improve their postural stability. And you also figure out how to manage their triggers. So that's what you focus on first, doing making sure your neurological exam is thorough. So,
And ma'am,
yeah.
I guess a physiology of hearing system and all also is important.
Yes, yes, definitely.
That's in first year only.
Yes. So anatomy again plays a huge role because often, like I mentioned, there could be vestibular neuritis, but we more often tend to see Bell's palsy, for example, or a Ramsey Hunt, where technically the facial nerve is involved, but due to the if you recollect anatomy, the facial nerve and the vestibulocochlear nerve are in very close proximity. So the inflammation of the facial nerve may show symptoms of vestibulocochlear nerve being inflamed as well. So again, you need to do a thorough medical history, like I kept repeating.
So, my question was, in your
Hmm.
clinical experience, what is the most common vestibular condition that patients come with?
So for a peripheral cause, definitely a BPPV, and for a central cause, a stroke, multiple sclerosis, and often, in fact, Parkinson's plus syndrome or Parkinson's disease. So those are common conditions that require vestibular rehab.
Priyanshi is asking, how long does vestibular rehab last?
So in a lot of cases, it does resolve in a session or two, and in some cases, it can be a matter of weeks to months. Depends on how from how long the symptom has been going on. Depends on the cause, and symptom also depends on the intensity of symptoms, and of course the patient goals.
So, Priyanshi is asking, which type of vestibular rehab we can perform in BPPV patients?
So there are specific repositioning maneuvers that you will have to learn hands-on. You can find a lot of these online as well, but I would recommend you do them in person if possible. You
Okay.
learn them
And
if possible. Yeah.
okay. And ma'am, I request you to send us some maneuvers, like if there is any video on YouTube or something.
Sure, sure. I'll do that.
Ma'am, if you plan any vestibular rehabilitation instructor course or something like that, you can share us.
As of now, I don't have any active plans, but as part of rehab praxis, which Payal shared earlier, we do bi-monthly. So every second and fourth Wednesday at 8 to 9, from 8 to 9, we do conduct these lecture series. And this month we are talking about vestibular rehab specifically in stroke. So एक
Okay.
lecture already हो गया है about the assessment, and on the 25th I'm going to be talking about the management.
Okay. I will share that link in the groups.
Yes, yes, definitely. I know there are a lot of limitations, and मैं एकदम डिटेल में नहीं जा सकती because there are a lot of things जो practical चीजें करके ही समझ में आएंगी.
Right.
So
नहीं
I may
ma'am,
not be able to do justice to
but
that.
you got to know a lot of about vestibular rehab. Like
Yes,
एक
yes.
प्लान बन गया कि हाँ ऐसा ऐसा होता है.
हाँ मतलब if it's something that interests you, they can you can figure out आगे कैसे फिर उसमें और
Yeah.
डिटेल सीख सकते हैं.
True. Like
But
पहले तो मुझे ये लगता था वेस्टिबुलर रिहैब इज लाइक वो मैनेवर को करो बस दैट इज वेस्टिबुलर
हाँ
रिहैब. Now I
नहीं
got
that's
to
so
know.
much more. In fact, न्यूरो कर रहे हो तो a lot of vestibular rehab is already happening.
Yeah.
So इसलिए न्यूरो एग्जाम एंड न्यूरो जो आप जो बेसिक है वो सीखना इज वेरी इम्पोर्टेंट.
True.
सो या
Anthony is asking, ma'am, so like you had mentioned eye vision problem or dizziness, so sometimes the patient will first consult an ENT specialist or a neurologist. So like how important is interdisciplinary collaboration between us and all other specialists in managing this vestibular disorders?
very very important, and this holds true for every condition that we manage along with other healthcare professions, because combined effort रहता है. For example, certain drugs, in fact, which are given for vertigo, if long term अगर indiscriminately use हो by patient, like हम डोलो जैसे पॉप करते हैं, अगर वैसे ही उन्होंने कंटिन्यू किया, so it can have ototoxicity, मतलब inner ear के जो cells होते हैं वो डैमेज हो सकते हैं, which is why communicating with the patient with their treating physician is very important. So interdisciplinary collaboration will take your treatment strategies and your treatment जो effect है, that will go from like 10% to like 90% of success, for example. So very important. Anurag has a few questions. What mistakes should beginners avoid during vestibular rehab? Not communicating with the patient about what to expect during the maneuver, for example, or the exercise that you give. What was the most interesting vestibular case? I described about it. It was a PCA stroke, um, and I'm interested in cardio. With the third question, I don't think I'm the right person to help you with the third question about your internship plans. Um, but
Anurag, there
yeah,
is no internship in AIMS. They only take employees, who be after exams.
Anthony, in my childhood, when I went for a roller coaster ride, I felt very dizzy while my brother was so enjoying the ride without any problems. So, why is that, ma'am? So, Anthony, पर्सनल डिफरेंसेस होते ही है इन योर anatomy, in your physiology, and in your tolerance to certain triggers or certain stimuli. So maybe you are not prepared for the amount of roller coaster का जो impact होने वाला है, stimulus होने वाला. Maybe you were not prepared for that. You were probably dehydrated. You were probably hungry. Could be multiple reasons. And probably younger kids sometimes tend to have lower tolerance to a lot of exciting stimuli. Could be that. Plus spinning hota hai, assuming it was a spinning roller coaster. So a lot of quick stimuli within a short span of time. Visual stimuli hota hai, auditory stimuli hota hai, vestibular stimuli hota hai.
Hmm.
हवा आती है.
That's that is happening in normal people also, right?
Yes, yes, that can very much happen. Once you sit in a very intense roller coaster and you get off it, for a few seconds, थोड़ा ऐसे you will feel कि थोड़ा off लग रहा है balance. Or if you have been swimming for a long time and then you come out, you feel कि I'm still floating. So all those are normal things. But and if it lasts for like more than 2-3 days and stuff, that's where you need to figure out if something is wrong.
Well, ma'am, Anthony is asking a lot of question in this session. I guess he's also interested in this.
Nice. I'm glad.
Anybody else want to ask any question? Also, ma'am, share this rehab praxis link also.
Sure, I will do that. I'll share it with you, Payal.
Yeah.
Yeah, I'll do that.
Okay.
All right, I
Okay.
think we're done with the questions.
Yeah. Thank you so much, ma'am.
Thank you so much for having me, and it was great. I loved answering all the questions. It was a fun session. Thank you so much.